Hi, everyone. Thank you for joining the May I-CPEN meeting. Tonight is very special. We have a lot of people from CPESN USA going to give us background information and answer any and all of your questions. So please keep a that. Um, I'm Lauren Yildiz, the Executive Fellow for the Illinois Pharmacists Association. I'm also the lead managing network facilitator with CPESN Illinois. So now I will hand it off to Cody Clifton.
Thanks, Lauren. Thank y'all for having us this afternoon. My name is Cody Clifton. I am a pharmacist and director of practice transformation and clinical programs with CPSN USA. Been with CPSN since it started, so I guess that's 7, 8 years ago now. So I probably have worked with some of you back during the COVID vaccine program days if you were getting your vaccine through CPSN, FRPP. So appreciate everything that y'all are doing in Illinois, and we're excited to hopefully address some of your questions, concerns tonight. And we've got a good group on with us tonight. So I'll pass it over to Ashley next to introduce herself. And Ashley, if you just want to pass it around, then I'll share my screen.
Thanks, Cody, and good evening, everybody. My name is Ashley Moose, Director of Network Development with CPSN USA. I'm also a pharmacy owner, Moose Pharmacy in Monroe, located just outside of Charlotte, North Carolina. I've also been with CPSN from the beginning, and prior to that, when we were just started out as a grant known as the Multi-State Pharmacy Collaborative, when the idea of creating a network of community pharmacies was starting to happen organically around the nation. As the idea and the mission of bringing together and aggregating community pharmacies to be able to express their value as a whole, as we began to bring across all the parties that were starting to organize, that's where CPSN was born. And we're just really grateful for the opportunity to be with you tonight and share where some great opportunities may be lying for community pharmacists in Illinois, and where we think that a network of aggregated community pharmacies in your state may really help to create synergies within your practice and within your business model. So thanks for having us tonight. And speaking of synergies in your business model, I'll pass it on to Leanne Haley Brown next to talk about her role with this whole CPSN initiative and how it's already changing my practice also. So Leanne, take it away.
Thanks, Ashley. So Leanne Haley Brown, I am the program lead for the Pharmacy Care at Home, which is sort of turned into an umbrella for all kinds of cool stuff that's going on, because I just like to dabble in all kinds of cool stuff, and everyone says we should do that. And I'm like, okay, we can do it over here. So very excited to have this program. I've been with CPESN as an employee since last September, have been in a support role with CPSN previous to that. So just a little bit over a year total working in the long-term care pharmacy at home space. I owned a pharmacy for 27 years that serviced long-term care, assisted living, independent living, and we did pharmacy care at home patients, except I'm old, so back then there really was no recognized pharmacy care at home. But I lived in a community that was very old, and a lot of the children had moved away because there were no opportunities, and they were willing to pay me cash to do a good job with medication management for their elderly patients. So I am connected industry wide. I'm sought after as an industry speaker and expert on this topic, and I'm very excited that I get to work for an organization now that is owned by independent pharmacies and is directed by independent pharmacies, because I have always come from a place of service, and I'm very excited to see that there's some excitement in Illinois, and I want to work really hard to help keep that momentum going. So thank you for having me tonight.
Madeline, do you want to go next? And then I think everyone's very familiar with Amy at this point, but Amy, you're welcome to introduce yourself too.
Sure. So my name is Madeline Clark, and I am the lead for the Next Generation Luminary Initiative. So working with people like Lauren across the country, which has been so wonderful. Also done some work with our students, but really just working with our networks, trying to find and develop our next generation of luminaries and leaders in these networks, people to engage within our pharmacies, and bring them up into working collaboratively across the network. So I'm really excited to be here with you all.
Hi, my name is Amy Schmidt. I'm the project support lead for Illinois, which means I'm kind of the connector between CPESN USA and your local network. In addition to that, I'm in Wyoming. My husband and I own a pharmacy there, and I'm the managing network facilitator for CPESN Wyoming. And so I feel like I have lots of fun ways to connect with you guys.
Awesome. Well, thank y'all for the introduction and again for the Illinois folks to have us here tonight. So we just want to make sure that you're aware of all the things going on within CPSN USA and then also at the local network levels. We all at the CPSN USA level, as Amy has alluded to there, we work with all the different networks across the country. So we do have a good lens on the different types of networks out there. Some are still very new and growing, establishing their network leadership, and some of them are in a transition phase. And then we've got some out there that are mature and bringing in millions of dollars to their local networks already. So you've got the experts on the line here tonight to hopefully help answer your questions in any type of setting. As we begin, just to go over our antitrust statement, what this does is help protect us from any antitrust laws, and it's very important, as you know, as a CPS and pharmacy participant, that we go over this during each meeting, which allows us to talk a little bit more freely amongst each other. So I'll just read this off the slide, and then I'm going to pass it over to Ashley just for a little bit more background on CPS in USA and where we are today as a whole. So this meeting is for the specific purpose described in the agenda. CPSM meetings are conducted in accordance with the antitrust laws of the United States. All participants should limit discussion to the topics set forth on the agenda and to the activities of the local network. Participation in CPSN networks is completely voluntary. Any questions or concerns about antitrust or any other legal matter should be directed to the meeting leader. There should be no informal, secret, or rump meetings in which some or all the attendees discuss business matters off the record. A disclaimer here is that this webinar is a production of CPSN Network, so I-CPEN. So Lauren, I'm sure will make sure that you all get the recording and the notes affiliated with it. But otherwise, outside of that, no AI-enabled recording devices are allowed. And then any questions or concerns about these guidelines or about any CPSN meetings or discussions, practices should be directed to CPSN USA LLC's Antitrust Counsel, Katie Funk, whose contact information is there on the screen for us. So with that, I'm going to pass it over to Ashley just to share with you a little bit more from her perspective too of how CPSN USA and your local network is very different than many of the things in the marketplace right now. So Ashley, I'm going to pass it over to you.
Thanks. I just want to do a quick sound check, Cody. Can you hear me okay? Because my audio is going in and out. Okay.
You're good.
Thank you. Well, again, good evening, everybody. Just to kind of jump in, I'm not sure where everybody is that's joining the call around kind of the background behind CPESN and why we're different. And I'll very briefly skim the surface because there's a lot of opportunity we want to make sure you're aware of. So I will talk a little bit about that. But I do want to offer an invitation if you'd like to learn more about the very basics of CPSN, why it was developed, and what what it looks like across networks of other states, what those opportunities are looking like by state, and more composite. We invite you to attend the Intro to CPSN webinar. We have them monthly in the evenings or in the afternoons, depending on the month. So they are called Intro to CPSN, and you can find access to those on the website cpsn.com. But for tonight's purposes, CPSN, why it was built, why are we different? It was very important as we began to determine the different challenges within the marketplace. We knew that as community pharmacy owners, and if we wanted to have something that one day we could pass along to another community pharmacy owner, that we had to change our business model. I think that many of us are getting along and we're making it happen with dispensing only. But whenever you couple dispensing services on top of clinical services and doing that in a high quality way, you're seeing a change within community pharmacy practice, not only in enjoying what you do every day, but also in the revenue model. And that's been very important as we have aggregated as community pharmacy owners committed to providing high quality care to our patients in community across a community, that it has changed and created a value in the marketplace. It's taken a little bit of a time to create that momentum, but now almost every state has had opportunities working with value purchasers, whether they are a health system, an ACO, a Medicare plan, a Medicaid plan. There are programs out there that they're looking for total dollar saved and total cost of care, and other types of metrics that are extremely important around cost savings. And they're looking to community pharmacy to provide that solution. What they're not looking for is community pharmacy that has to hurry up and figure out where a network is or where a network isn't formed yet and create that. They want a ready-made network, ready to go and offer solutions for particular metrics. So that's what CPESN is about. It's about creating transparency and value contracting on and that sustainability of independent community pharmacy across the boards. We are not a third party. We are not an association. We are not a PSAO. We are not a GPO. We are a clinically integrated network of providers. And that is, I think, probably one of the key aspects that that allows us to be synergistic with associations, with PSAOs or GPOs, but we focus on the service side of the value we provide and being paid and compensated fairly for providing services within our community pharmacies. What that means, adherence programs, delivery services, access to care, counseling on medications, lots of different services where this could be, but mainly it's holding that deep relationship with patients within your community and being able to provide coordination of care efforts to make sure patients have access to their medications. As a nationally clinically integrated network, there are 48 local networks that exist across the United States in 45 different states. Some of our larger states or more densely populated states have networks that oftentimes interact really well together, where there may be multiple networks within a state, but they kind of divide and conquer based on regional areas or particular payer programs that may exist for participating pharmacies within those networks. As a CIN or clinically integrated network, it is a legal construct that will allow us to work together to discuss the transparency of these service-based contracts. That's not in violation of antitrust law. So by doing this, we can come together and decide what is fair for the types of services we're providing, and how does that translate across the borders of our states where we're performing a service, we feel like we're fairly paid for it, and that one state's not getting some type of contract that's undercutting another state. There's opportunity to really be paid for your value, but oftentimes being bonused for the value that you provide based on the payment model, the contract, and the opportunities that you have, the lives that you're serving in your state. What we believe, and really the cornerstone of CPESN, is that local relationships drive quality care. The local networks drive the payer relationships, services, and innovation. There is there's nobody that can serve your community better than you, your local, and trying to outsource that or outsmart that business model just can't happen. We've seen it time and time again, and we know that, the COVID response, who was there? Today, you've probably solved 25 problems for patient access that no one else could if you weren't in that community. So, what would happen if you had to go away? That's the local care and the local network model is what we want to support and what we're here for as we continue on. And I'll even say selfishly, the stronger the Illinois network is, the stronger it makes the North Carolina network because there's strong networks across the nation. The better it is for all of us, and it creates more of a marketplace presence when we know that payers that we also serve and that you also serve, they can come to CPESN, work with Illinois, work with Michigan, go all the way down the line. We're a solution to a hard problem, and you're already doing many of these activities. So, Cody, tell us about some of those activities.
Yeah, for sure. Thanks, Ashley. And feel free, if you've got questions or anything throughout, feel free to unmute, raise your hand. I'm sure Lauren will stop us or put into the chat box. We're happy to answer questions along the way too. I will say, and Ashley, Leanne, Madeline, Amy, correct me where I'm wrong, but I think CPSN, if as a group of pharmacies, is the third largest group of pharmacies in the country at this time. Is that correct, or is it the fourth? Third?
The last,
Okay.
okay, yeah.
I see Leanne's
I,
fingers
I
going up.
believe it's third.
Okay,
And I
awesome.
believe, yeah, I'm pretty sure, unless Ashley's got something more up to date. When I came on board September, I thought we were third.
3,500 participating pharmacies across the nation. So it gives
Yeah.
us a pretty good footprint where we're covering the majority of the United States by delivery services alone.
Yeah. And that's super important too, as we go, as Ashley was saying, go in to have these contract discussions because they need to know that we have a number of pharmacies that cover the lives of the patients that they have members for. And so, interestingly enough, I know for a fact, just from recent conversations in Arkansas, they are the biggest chain of pharmacies. If you look at it by chain type, of pharmacies in Arkansas. So the CPSN pharmacies are the biggest group of pharmacies there in Arkansas. And Bree called out that Walmart is based there. So that's very interesting. It shows like how rural Arkansas is and other states. I'm sure Illinois, of course, has some rural spots too that you all are serving patients on. So you're super important to the equation. And I think it's very valuable as hearing with this Arkansas Blue Cross Blue Shield conversation that they're so interested in partnering with CPSN Arkansas just to figure out how they can help to improve the lives of their patients. So I think that's really cool. And so you're very important to the equation from a health plan perspective. On this slide here, it just shows some of the impact. You may have seen this number in some of the Sunday updates, or maybe you're too busy to look at those emails that you're getting from CPSN USA, or maybe Lauren and Starlin and Garth, et cetera, are passing that on to y'all in other venues. But in 2025 alone, we had $37.5 million of opportunities in the 3,400, 3,500 CPSN pharmacies. And I'm sure as you're on the call tonight, you're like, where was that for Illinois? So we're happy to talk with you about that too and figure out what are some solutions to get those dollars to your pharmacies too. Even though there was this many dollars on the table in 2025, I would say only about a fourth of those dollars were actually captured in 2024. And so this should say 2024, not 2025 on the slide here. And I'll follow up with Jay about that. But on this piece here, there's all kinds of barriers to this too in capturing that. So being ready to deliver on the payer programs when they do come to your pharmacy is super important. So if any of you participated in Flip the Pharmacy or anything like that, that really helps ready your pharmacy. Really having a good med-sync process in place makes a tremendous difference so that you can really focus in on those services for the patients versus trying to figure out all the just the prescription workflow pieces. So with that, we've currently in 2025 have over 100 active contracts with major health plans. The three listed on the screen here are probably some of our most scalable programs that we currently have. I'll go into a little bit more detail about that in just a moment, but those are with United Healthcare, Elevance Health, and Centene. And so many of these programs too are in Medicaid populations. There are some in commercial populations too. We're starting to slowly crack the nut on the Medicare opportunities under the value-based care opportunities. And a lot of that too is being driven by the Pharmacy Care at Home initiative too. So within 2024, networks had an average of $10,000 per pharmacy per year in the service revenues based on the data that we've looked at. And then it's really has added dollars back to the bottom line of the pharmacy. Our goal with these services are not to make up dollars for losing the money on the dispensing side, but really to show your value and get paid for the services. And the dispensing piece is your touch point with the patient. I will say with one of the Elevance Health programs, again, this is your network. You get to decide what you're going to do, what you're not going to do. So you get to opt into these programs. You get to see these contracts before you sign on to them and be comfortable with that in the first place. But one instance in Virginia is that they had the Elevance Health program there. Again, I'll go into a little bit more detail about that in a minute, but they had terrible reimbursement on the drug side. And it's just, I know every state is a war zone when it comes to the drug reimbursement aspect, but it certainly is in Virginia too. And so much that it was really impacting the service opportunity. And ultimately, CPESN is not an advocacy arm of the world of pharmacy. We're here to get pharmacies paid for services. That's where associations come into play. And we really lean on those relationships for that. But what we did not expect through having these service-based opportunities is really that being a tool in our toolbox to help fight PBM reform. And so in Virginia, it did that. They just had their bill passed too on PBM reform, and we're hopeful that Virginia will get back started with Elevance, but they were part of the Elevance Health Program with CPESN for 1 to 2 years. And then they were like, we can't keep doing this. We're losing $50 on an inhaler, and that's what we're supposed to be focused on getting these patients better. And so we don't feel like we can deliver on these services and serve our patients without being paid fairly on the product side and on the service side. So they effectively terminated their Elevance Health contract for the services starting in January. But it really goes to show we've got a lot of different avenues to that we didn't even realize about having these conversations on the dispensing side. That's why I went down that rabbit hole there. But then it again just shows the value of being able to come at this from so many different angles for this reform that needs to happen. And so within this Elevance Health program, there's been 2 published reports about cost savings provided in 2023 and 2024 from the CPESN pharmacies. This program started first in Iowa and Arkansas, and essentially they approved the concept there, and then other Medicaid plans wanted to come on board with that program. And so now it's live in 11 different states currently for the Medicaid population. And I would say this is one of our most scalable programs. I know Starlin mentioned Elevance Health does not do business there within Illinois, but certainly we can have these types of conversations with the Medicaid plans, no matter if they're using Elevance Health or not. We can go directly to the Medicaid plan. So just know all of this stuff that we're talking about is very applicable to Illinois. It's just how do we get it started there in Illinois? And so that's where a lot of the conversation will be in. So Starlin, I'll turn it over to you because I saw you come unmuted.
Well, no, I just wanted to say that the RFP just opened for Illinois. So if they're not doing it now, and I've had people inquire who to contact. So we've been sending the email to the Medicaid Managed Care organization, the Illinois so that hopefully they'll come here.
Yeah, that's awesome. And interestingly enough, CPSN pharmacies are becoming part of those RFPs and bids within the state because they recognize the value that CPSN pharmacies are bringing to the table in improving quality metrics and saving cost for the plans and the patients overall. So certainly keep that word going, and hopefully something will stick there for the next RFP there. So there's all kind, we're happy to put those links in chat box, or can send them to Lauren and et cetera after the meeting too, so that you can see that. But really cool stuff is happening. And so one of the other aspects, I know y'all probably talked about this some, is around the fee change structure that's occurring. And Leanne is going to talk more about where the pharmacy care at home is coming into play in just a minute. But really what we're looking for with the changing times is just sustaining growth and innovation for CPS and pharmacies, aligning fees with the value that you receive. And you may be like, what are we receiving? And so again, that's one of the things we're here to talk with you about this evening. And then also supporting net-wide access to vital services. So we're trying to get dollars back to the local networks so they can have those dollars too to help support the local endeavors, because just CPSN USA cannot do it. We've got to lean on the local Illinois folks to actually get some of that work done and utilize those relationships too. Because that's just like in pharmacy and serving your patients, everything works better at a local opportunity. And so this is the first fee increase in the nine-year history of CPSN USA. And I'll certainly allow Ashley, especially with her owner hat, and then also having understand the value that it's brought to her pharmacies. Talk a little bit more about that, and I'll bring up this slide too now that you can read through some of the current offerings and what's going to be happening in the future. So Ashley, if you want to talk through that and this slide, that'd be wonderful.
Yeah, I guess for me, it's not a fee increase because I have two MPIs as part of CPSN. I have my community retail pharmacy, and then I have my long-term care side because I am a combo shop offering both long-term care and um, retail or community pharmacy traditional services. And so for me, this is a great thing, right? Because it's I'm not paying 295s, I'm paying 125, and that's the difference. And but then there's also additional added benefits that are coming in around business intelligence programs. And there's so much data that's getting ready to be released with the business intelligence program that's specific to your pharmacy and perhaps opportunities that you may be missing in terms of, who would be great for an LTC at home candidate versus or a traditional pharmacy candidate under that MPI. So it's going to help us better differentiate based on contracts, kind of the business intelligent decisions that you have to make, and have a dashboard of information that you can react to versus running reports and when you have time, or trying to figure out the analytics on your own. That this is an added value that's going to be coming in. So I think that if you are a pharmacy that's considering LTC at home services. And again, Leanne's going to share with you and probably highly encourage you to be a part of that, because there are opportunities for you. And I don't think the number of patients you're serving in that capacity is a limitation. I think it can help really jumpstart a model change in your community pharmacy if you aren't already considering that opportunity. It's not a heavy lift to get into, but there is some things you need to know to do it with high quality. So again, there is a new fee structure that's getting introduced on July 1, where it's 125 as a location, but it includes your pharmacy care at home program and business intelligence.
Any questions about that? I'm going to change things up a little bit because I've been talking a lot and ask Leanne to talk through her slides, and then we'll go back through the other payer opportunities just to understand what's out there, even though I've kind of touched on that to some. So, Leanne, if you're good with that, I
Oh,
don't see
sure.
any chats coming through unless
I,
Lauren is being
this is getting to be a bit rote for me at this point. So so these slides are actually just came from a town hall that Ashley's husband and partner in crime, Joe Moose, and I did, where we talked about pharmacy care at home and why CPESN and frankly pharmacy care at home are so important
Mhm.
for the pharmacy business model today. So that's my pretty beginning slide. Thanks, Cody, for putting the logo on it for me. I forget to do that sometimes. So yeah, and it's really about what we're doing beyond the script, frankly. This is why I like this title. It's why CPESN and pharmacy care at home as really a cornerstone program matters more now more than ever. Part of the reason why the CPESN leadership, which by the way is all the pharmacies that are paying the location fee. There aren't people telling the pharmacy owners what to do. It's the pharmacy owners and governance telling us what you need for us to do for you. So that's part of what I love. This is the team for pharmacy care at home. We've got Randy McDonough, who has been a luminary and he's way more than that. He's been an industry advocate. He's the current APHA president. He's our business lead. He and his team there in the row, they assist me at all times with content and putting out implementation guides. And then we've got our 4 luminary committees, and these are folks who are actively doing long-term care, have done long-term care, are doing pharmacy care at home. All of them are in the BI, the Business Intelligence Program. So it's a bunch of us who have done it or are currently doing it. And that's really what makes, in my opinion, pharmacy care at home special. The value of the program that we have here at CPESN is the experience and the support that pharmacies receive in getting their organization ready to identify and enroll patients. You're getting industry expert advice. I mean, I teach the business of long-term care for NCPA. I'm doing a mini business of long-term care for Cardinal Health. I'm speaking 4 things at the Georgia Pharmacists Association meeting, so over and over and over, people come to CPESN looking for industry experts to be able to educate their folks at conferences and things. We've got all the templates you need to be compliant, the active measures, follow-ups, reducing audit exposure. It's really kind of cool. And the value, they're twofold, really. Part of the reason it was important to go, I felt, to the location based, and although it wasn't my decision, I was really excited that it was decided this way because we've seen, as Ashley said, time and again, we've got 3,500 community retail NPIs. At the moment, we don't have everybody's long-term care NPIs. We have owners like Ashley. We've got owners like Aaron Land, Elizabeth Locklear, who all came in early and put their long-term care NPIs into our system. But what we saw was there were folks that had long-term care NPIs that didn't have them subscribed to CPESN that were missing opportunities for United Healthcare or Elevance because Elevance and United Healthcare had no idea that they had a long-term care NPI. So that was one of the reasons where if you're the days of having just a retail taxonomy at a community pharmacy, those unfortunately are a lot of the folks that have already gone by the wayside. There are many of you that have multiple NPIs out of the same location. You may have a specialty, you may have infusion, you may have long-term care. So it makes the most sense for us to do this location-based because suddenly everybody brings their long-term care NPIs in. From my best guess, by July 2nd, we're going to have 1,000 long-term care MPIs in the CPESN continuum. And suddenly that makes the payer conversation look totally different. It looks completely different because now we know what network sufficiency that we can bring to these payers. And that is so mission critical. So, what are you missing if you don't do this? Industry expert coaching and guidance. We are so rife with people who have been there, who have done that, and not just people who have been doing it for years. Ashley got into this and started from zero and went to a whole big bunch of people. I've got folks at every level, just getting started, don't have a long-term care NPI yet. They're working on that. We're helping them get contracted. We're supporting them with that. We do bi-weekly webinars and they always have action items. This is what we're talking about this week. This is what you need to go back to your pharmacy and do. It's always applicable information for patient care or business operations to implement in your pharmacy. Replay links are emailed after every webinar. We've got a private pharmacy Facebook group. Ashley and I were talking before this meeting started about some scuttlebutt in the Pioneer Facebook group. If you have Pioneer and you're not in that Facebook group, you're really missing out. I'd say the same thing about the Pharmacy Care at Home Facebook group, because we are constantly saying, hey, who's doing this? Who's doing that? Why won't Elevate do this? It's all we get a little bit wild in there sometimes, but I also send out a weekly newsletter that's called Step to Success. It's industry hot topics. It's always something that's needed. It's who got audited for what this week, or Optum has gone crazy and y'all better go to the local Lowe's or Home Depot and buy an emergency box or write an emergency box on it, throw it in your bathroom, because some of these auditors don't really understand pharmacy care at home at all. Yeah, exactly, Starlin. The silver tsunami is coming. We're losing 415 skilled nursing beds for every 10,000 patients every single month. So where the population over 75 is going to double by 2050. There'll be more people over the age of 65 than are under the age of 35 to pay for them. Yes, darling, me too. And with the loss of those skilled nursing beds, those less complex skilled nursing people will have to take up assisted living beds. So assisted livings will become a more moderate complexity venue. The patients who are low complexity that would qualify for assisted living, they have nowhere to go. They have to stay home. And we have to be the ones to grab this business, because we let nurse practitioners take what we could have had for a scope of practice early on, and I'm not going to let that happen with this. So, we do weekly audit tips, and that expansion of benefits, the business intelligence, we're going to talk about more on the next slide. I'm really excited about that as well. So next slide, Cody. Thank you, sir. So I haven't joined yet. Why should I? Well, number one is access to payer contracts that reward enhanced services for both your community retail MPI and your long-term care MPI. That was a huge gap in what we came up with by ourselves. So we've got some folks that have got their long-term care MPI getting some Elevance stuff. The support and training for implementing clinical services. Pharmacy care at home is a practice transformation. I know practice transformation. There are people who are like, oh, you CPESN people, you talk about practice transformation. I'm like, yeah, we talk about it, but better yet, we actually do it. And you've got this whole staff, and you've got all the other independent pharmacy owners that will help you transform your practice, because I do believe that the future, it's a vision of what pharmacy care at home really is. The dispensing part we help you with. I've got anything you need. I just had somebody today who was like, oh my God, I need a drug template for destruction in assisted livings. I'm like, okay. And I just emailed it to her, and she's like, how did you get that to me so fast? I'm like, because we have everything you'll need. Just ask, you shall receive. So the support and the training and the being as audit proof as possible is very important to me. I owned a pharmacy for 27 years. I hate auditors. I hate audits, and I don't want anyone to lose one single cent. The data insights that are going to be available very soon, will improve patient care and business performance for both of your MPIs. And who doesn't want that? Yeah, we want to get some more money on the dispensing if we can. But the real vision is, we want our patients to stay in our community. We want them to stay happy and healthy in their homes for as long as possible. Gallup tells us over and over and over again that 92% of patients over 55 years old want to age in their homes. So let's make that happen. Collaboration with like-minded pharmacies and healthcare providers. It was interesting when Starlin was talking earlier today that she was in a meeting where a provider said to her, I had no idea that you guys could do all this stuff. So that's also part of what we're doing, is getting the message out, and helping other healthcare providers understand what pharmacists are capable of doing. And then another new thing is the CPESN Remote Care Initiative, which fell under the Pharmacy Care at Home program because it's kind of a pet thing of mine, and I happen to have the skill set to make it happen. So that's under Pharmacy Care at Home. If you're looking for a compliant way to be able to select a technology service provider so that you can do additional clinical services through collaborating with RTM or RPM, this is going to be very exciting. We've got 2 technology service providers so far. They're going to be a full data share with us, so that will be even more data that we'll be able to compile and put out to payers to show what our outcomes look like for their patients and our patients. So next slide, please, Cody. So I have data now, super excited. What are the best practices? And I cannot speak intelligently about e-care plans. That would be Cody if you have in-depth questions. But you know what? One of the things that CPESN did way before me, and Cody has pushed this happily and very well, is to standardize documentations with the e-care plan functionality. The biggest pharmacy management systems got their stuff together and they made standardized e-care plans. And so now payers are saying, oh, the CPESN standardization is the e-care plan. That's what we need, because they're getting used to that. So I think that the CPESN e-care plan will sort of become the Kleenex of e-care plans in the universe very soon. Our ability to track key metrics like medication adherence, interventions, and outcomes, not only in the e-care plan, we can tailor that to whatever a payer wants to see. That's the beauty of the way the e-care plans have expanded over time. There's a SNOMED code for whatever a payer comes to you and wants to track. So if someone local is to come to Starlin and say, oh, we want to track, we want pharmacies to gather this little piece of data point for everyone, we can make that happen. CPESN can create an e-care plan to report that information back to however customized they want it. So it's very exciting. And then in terms of the business intelligence, once both MPIs are in there, we're designing custom dashboards to identify trends and opportunities, including patients that may be eligible for pharmacy care at home. So say you get 3 patients on a Friday coming out of the local hospital system with a bunch of meds, and you just fill them under retail and blah, blah, blah. And all of a sudden on your next dashboard, 2 of those patients could potentially qualify at pharmacy care at home. Maybe you should be billing them on your long-term care contract. That's how exciting it is, what business intelligence is going to be able to tell you, so that maybe you can take a breath and go fishing one day instead of spending an entire day trying to pull reports and make sure you're not missing an opportunity. And the ability to engage staff and data-driven decision-making. In my 27 years as a pharmacy owner, y'all know this already, but how many decisions have you had to make because all you had to decide was your gut? I think this is a good idea, and I'm going to give it a whirl. Okay, that we know it's a shame that that's the way pharmacy is, but the shame is that's the way it's always been. With the business intelligence that we have, it doesn't have to be that way anymore. And if you're not in any sort of business intelligence yet, and you're thinking about doing pharmacy care at home, let me know. We can pull a report. I'll shove it through my little algorithm and I'll tell you how many patients you probably have. And that's another conversation too, but let's get to the next slide, Cody. Because one of the things a lot of pharmacies are told, they approach a long-term care PSAO, GPO, and they're told, oh, if you don't have 50 patients, this isn't good for you. Okay, well, if you don't have 50 patients, it's not real good for them, but it's still good for you. I was just on another webinar this week with a pharmacist that only showcased 2 patients out of the 22 patients that she has now, and those 2 patients are offsetting all of her monthly costs. 2 patients. So don't let any conversation you may have had with a PSAO telling you don't have enough patients. That's hogswallop, and I'm happy to give an introduction because all the PSAOs now are like, oh, it's a Leanne introduction. Please don't give them any malarkey. So next slide, please, Cody. Oh my gosh, I'm done already?
You're already done, Leanne.
Woohoo!
Hey Cody, could I just add 2 quick things in really fast?
Absolutely.
Leanne, you referenced a webinar that you did recently with Joe about that for the listeners tonight, that is the CPESN town hall that we have on a regular basis, and that's CPESN's vehicle for one of the vehicles for communication to you. So if you kind of want to be tapped into what the newest thing is or need a little bit more information that what's coming from CPESN USA, attend those, because that is one way we can kind of get into more detail around some of the initiatives or some of the things that you just absolutely, we believe you need to know about. The second thing that I'll say before I turn it to Cody to get into the Illinois specific data is that we've talked about value-based contracts, we've talked about subject matter expertise and pharmacy care at home. There's also subject matter expertise in medical billing supports. If you have or desire to have a medical clinic within your pharmacy, there's subject matter experts around that. Remote patient monitoring, there's subject matter expert. So there's a lot of different avenues that you as a community pharmacy can get tapped in and share information back and forth across industry experts there. So I just want to make sure you know about that. If you don't, you can go to cpsn.com/marketplace to learn more about those things. Back to you.
And Ashley, Byron, I just want to let you know, I know you were at the town hall on Tuesday, and I owe you an email. You're on my list.
Awesome. Ashley, thanks for going over that. And we won't spend any more time on this slide, but at the end of the day, CPESN here is for value-based contracting, but we are trying to get you whatever opportunity that may be a good fit to your pharmacy, so that you can focus on something as you wait for these value-based contracting too. And hopefully both of those will play off of each other. So definitely attend those town halls so that you can learn more about that and go to that marketplace there to find out more about each one of these different special purpose programs. So I'm going to try to fly through these slides. I know we're getting so close to time and everybody's probably getting ready for bed. But you'll have these slides afterward too. Lauren can get those to you. But this is just what we're talking with payers about when we start having these conversations. And a lot of this may look scary, but it's stuff that you're already doing in the pharmacy. Whenever you're getting a contract, you're just like, how do I get this into my workflow to make sure I capitalize on that opportunity? So I will say, don't be worried too much about practice transformation. To Leanne's point earlier, it sounds a little bit more scarier than it actually is, because pharmacy staff members are very notorious about not giving themselves enough credit, and you are making a big impact. So that's why we're trying to fight so hard to get you paid for these dollars. And we won't go too much into the pharmacist e-care plan here. But as you all know, it's a requirement to have the e-care plan functionality after 6 months of being with CPESN. And one reason why that is super important from the quality committee standpoint, which is, again, your peers that lead that, is that they want to make sure that you're ready for these payer programs as we continue to push the e-care plan. for an opportunity to get paid, just so that you're not having to sign into a different documentation system. One other point real quick before I forget, I was just thinking about this when Leanne was talking, is I know we're talking about data a lot throughout this conversation and analyzing your data and getting that information back to you so that you can use it. Rest assured that CPESN has these agreements in place, that we can't sell your data or do anything with that data. It is yours. We're just trying to help be a conduit to better understand that data. So do understand that. We're just trying to make sure that you are being protected. The board is, so that we can't do anything with your data, and then also moving opportunities forward. But this one fact here real quick is just at least 1/3 of payments that went to CPESN pharmacies in 2024 were from the e-care plan documentation. So I think that's really cool, just because we haven't been doing that in the past. So I'll pause there. I think there's some comments coming from the audience.
Yeah, there's a question from one
Yeah.
of our participants. It says, can you go back to the advanced care synchronization slide?
Yeah, let's see. This one here.
I believe so.
Yeah, because that's my favorite slide.
Yeah.
Yeah.
But Rupesh wanted to see it.
Yeah, for sure. Yeah, so a lot of these services that we talk with payers about is we've got all these basic services that we can do, but around advanced care synchronization, we can add on these different services here. And just to give you a little bit of a flavor for the reimbursement for these contracts for the value-based care side, for the Elevance Health Program specifically, um, all of these services on the left-hand side are being done within the program, except for congestive heart failure and maternal health and opioid use supports. Many of these things like pharmacy care at home and transitions of care are kind of intertwined with some of these condition-focused management programs here. So hopefully as we get more LTC NPIs on file, that's where that's going to open up a lot more for pharmacy care at home. But within these different services here, pharmacies are getting paid $95 for an initial encounter with the patient. And that is, they're syncing their medications, they're doing medication reconciliation one time, and then they're offering med packaging, and that can come in a variety of different methods, and then offering home delivery. So it's at least offering those last two, but then requiring MedSync and MedRec. And ultimately, in the follow-up encounters, what we're really focused in on is the HEDIS metric that the plan has called out. So for diabetes, for example, we are trying to get their A1Cs less than 8% by doing these interventions. And so every month, the pharmacies are paid $25 per e-care plan submitted that has those interventions in there. One other really cool opportunity, and Lisa, I'll come to you next after this, is that we're now able to collect A1, pharmacists are able to do the A1Cs within their pharmacy practice and document that in the e-care plan, and that counts for a HEDIS measure, which is really, really huge, because we've been working for that for so long, because we're trying to get out of all these different other vendors being utilized and taking money off the top of the contracts that you deserve. And so that's really a big feat in this area because payers are also tired of paying vendors, or health plans are tired of paying vendors because there's so many extra costs associated with that. And CPESN again is a pass through, so we're sending those dollars directly to the pharmacy. And for the A1Cs, they get paid $45 per A1C done. And then at the end of the year, if those gaps are improved, A1C less than 8%, that's another $60. So that A1C that was $45 is actually $105 now. And then every gap closed is $60. So within the Elevance Health Program, in about 300 pharmacies, about $1.4 million went back to the pharmacies for fee-for-service payments and value-based care payments, which I think is really cool, to see that level of dollars in a program going back to those pharmacies. So it's happening out there. We just got to get to Illinois. Lisa, go ahead. Sorry to keep talking there.
No, that's okay. With the packaging, you said medication packaging, is that like disc bill? Because we have a couple where we do disc bill. Does that qualify as the packaging?
Yeah, it would. So it's
And do
very,
you get
oh,
that every month?
yeah, it's every month. So it's $95 for the first encounter, which would include that, and then it's $25 per month every time after that. So essentially in a year, it's about $450 that or 300 something dollars that you would earn on that patient. And then if you're doing all those encounters, and then you've got that opportunity for the value-based care too at the end.
Okay.
Yeah, so they're very flexible, and most payers are, or health plans are very flexible when it comes to the type of packaging that you're doing. Ultimately, they're trying to make sure that those patients are adherent. Rupesh, I see that your hand is up too. I don't know if I'm missing any questions. Let me know if
Just,
I am.
just to add on to Lisa's question.
Mm-hmm.
So we do the bubble pack, multi-bubble packs for the patients. The first time the patient comes in, we go through all their meds, we organize their meds, we have a more manual format. We create a spreadsheet for them, and we have
Mm-hmm.
a spreadsheet, and we follow up from there. So you're telling me that I can actually bill somebody for that service
Yeah,
in Illinois?
well, when we get you a contract in Illinois for with these health plans, you would be able to, and that happens through the e-care plan. So that's in these 11 states where Elevance Health is live with the Medicaid state plans. That's actually occurring there, and they're documenting it in the care plan and being paid.
So at the current time in Illinois, we can't bill for that, correct?
Not currently with any health plans under the CPESN contracts. That's what we're working to, and hopefully we can talk about some strategies here in just a second about how we can accomplish that.
All right, thank you.
Yeah, yeah. Great questions and comments. I'm just going to pull up a couple quick things here, and then I'm going to pass it over to Madeline. I know we're at the hour, but this is just 2024 in review for Illinois. I'm hopeful that it's going to be a lot more than this in 2025. Got to get those contracts down, but we had a QIO program from Telegen that 11 pharmacies in Illinois participated in, and $26,000 were earned for those 11 pharmacies that participated in that on an average of about $2,400. And if you do the quick math at the current participation fees, that was about doubling the dollars there that you would have paid in for your participation fees. So it does happen out there, just so that you know that your dollars not going into a black hole. They're supporting a lot of these best practice sharing and the special purpose programs that you have the opportunity for, but also to try to get these contracts to your pharmacies. So this was one small program, but what we're seeing is these smaller programs start up, and then everything starts to happen consecutively after that. Before this, one pharmacy participated in a Humana program that was paid a couple $1,000s back in 2020 or 2022. So again, we're trying to get this momentum started there in Illinois for you too. So with that, I'm going to go over the quality metrics real quick, and I think it'd be great to end on just next steps here in leadership thinking and how you can get involved. This is just Illinois' metrics for 2024 for the quality assurance standard. Happy to go back to this after Madeline if y'all have got questions about it. But what I did was put Illinois or I-CPEN pharmacies down here so you could see as of the 20th where all the pharmacies stand. 12 pharmacies, I'm skipping down here to the bottom, submitted at least 10 e-care plans in a quarter or participated in a payer program that used the e-care plan. Two pharmacies were not required because they had joined less than 6 months back in December 2024. Two met a practice transformation set here. So if you're involved in payer programs that don't involve the care plan, that also checks that box there too. So the quality committee is trying to not make this cumbersome for pharmacies to meet, but just as we have these payer conversations, we're able to help tell them what is actually happening from a clinically integrated network standpoint and making sure that we have quality pharmacies, which goes a very long way in those conversations. And then up here is just where we've landed on the pharmacy self-assessment completions. 10 pharmacies out of the 42 that were required completed those. 14 met that list of quality-based metrics, so you put those two together for care planning and practice transformation. And 10 people have completed the opioid stewardship plan attestation. So the self-assessment and opioid plan attestation and all this, great job for meeting these. What the quality committee, I think, is going to land on is keeping these two open for the pharmacy self-assessment and the opioid stewardship plan throughout this year for pharmacies to complete that. So if you didn't get that done, no problem. We know you got a lot going on. And then we will be giving some extra supports and meeting some of this practice transformation services performance throughout the rest of this year. And we'll talk more about that at a later time since we've already covered so much ground tonight. So with that, I'm happy to take any questions on that. Feel free to type them into the chat box. But I'm going to turn over to Madeline to talk about this leadership group that we've got going on, and really where she's going to focus in on is the next gen luminary leaders. And of course, luminary leaders kind of go hand in hand there because we, again, as we've said before, CPESN USA can't do all this work. We've got to have local network people that have those connections to help get these conversations started, and we can help support those and entertain those conversations. So, Madeline, thanks for your patience for us getting to this very important topic, but over to you about the leadership initiative.
Yeah, absolutely. And I'll try to go through these pretty quickly. The biggest thing is the CPSN Leadership Initiative. I love the term, it's a celebration initiative. So our pharmacies take more than the pharmacist. I could not think about completing my residency without the incredible technicians, cashiers, delivery drivers, everybody that works beside me every single day, which in CPESN are beacon leaders at schools and colleges of pharmacy. Faculty members who are committed to community pharmacy, and then, of course, our incredible students who are interning, doing rotations at our pharmacies. So those are some of the other groups that we really want to recognize. But then I am specifically focusing on Next Gen Luminary Leader, and I think one of the biggest things that I just wanted to touch on after hearing about all of the hopefully opportunities that are coming to Illinois, and you can't do this by yourself. It does take a team. And so really working with the team, and a lot of this is new technology. And so investing in teammates that know how to or can learn how to support your pharmacy through these initiatives, working with payers, doing more of these clinical services. I think that there are a lot of people Lauren and my age that come out of pharmacy school and love community pharmacy, but want to do more than just stand and check prescriptions all day. We want to have these clinical impacts. And so that is kind of the goal, to aggregate us together, share best practices. We have monthly meetings. And really just try and work together. We are going to start our Luminary Development Series this next month, starting in June. So if there's anybody you'd recommend, please send them to Lauren. She can forward me their information. I'd love to talk to them or connect with them. But that's the biggest thing. The topics are requested by our members. We say newer practitioners. However, at mid-year, we were talking about who's next in your pharmacy, who's next in your network leadership. Lauren is a great example of this. She's doing incredible things. So think of the Laurens in your pharmacy, and those are the people we want to continue to get involved. And if I just sold you as a next gen or somebody to sign up, or student, or if you have beacons in your pharmacy, you can sign them up through cpsnleads.com, and they'll get on our email list and all that good stuff. So that's the biggest thing, and you should have the slides if you have any questions.
Thank you, Madeline. And as Madeline said, I think the biggest take-home point, all this stuff can be so overwhelming, but if we can get more people involved, network level, pharmacy level, it becomes less of a burden for everybody, and it actually makes it more doable too. So this initiative hopefully will help you too, from a pharmacy standpoint, to not have to worry about training technicians to be the all-stars. You know that they have it in them, but you don't have the time to spend to educate them. So within the Beacon program, as Madeline was stating too, we bring technicians from across the country together so we can learn together, just like how Leanne was talking about with pharmacy care at home. So with that, those were our slides for tonight. There's a few that we skipped over. Sorry that we've gone over, but we're happy to stay on and answer additional questions too on what are the next steps with Illinois? How do we reinvigorate and get other people involved so that we can get some of these contracts there at the local network too. So Ashley, I'm going to turn it back over to you with that segue, and just talk about some of your experience with that. And maybe you can get some interest from the audience, or maybe some questions about that.
Thank you, Cody. So yeah, like the team. Well, first of all, thank you guys. Thank you for your time. Thank you for your expertise and your just, I guess, like just your experience. Thank you for sharing that and your knowledge and your willingness to help, because you guys have all been helpful for me. But like they said, I need people involved, because our network will fail if people are not engaged and involved. And I know I've been saying that since January. So I am looking for next gen leaders. I know we have a few students on this call as well. If you are interested, please email me, text me. You guys have my numbers. If you still don't know where to start or have questions, we can set up a one-on-one. You guys know me. I'm an email away. I would be happy to meet with you and talk to you more about I-CPEN and like what your role is, how we get you started. And I know there are a few concerns or questions that you may have, so now would be a great time to share that with the team so that they can answer it better than I can answer it.
Lauren, do we have I guess like an ETA of what we're hopeful to be able to do this in Illinois, or do we know how far we are into that process?
Sterling, go ahead.
Well, Lisa, you're more into it than anybody else on this call.
Sorry.
You are lead pharmacy technician, top diabetes DPP lead. You're a high vaccinator, immunizer. You're in the Healthy Heart Ambassadors program where you're monitoring blood pressure. So if we could replicate you about 52 times, we would have 52 pharmacies with Elisa that would help be the wing person and the lead with their pharmacy in helping us meet our grant obligations that tie into our CPESN quality standards. That's why I like the one slide that shows all those disease states. So we can, our grants can help seed the process. We can't pay for the whole thing because we aren't like Missouri that got $1.5 million. Yes, I have state envy. But we have things to get people trained and started. And Rupesh, you're on the lead. Byron, you're a lead. Is anybody from Moreland and Devitt? So we have these pharmacies, but we need all 52 pharmacies doing something. Not everybody can do everything. But if you do one expanded program and fill out your survey, because if Lauren and I and the other team don't have that survey, we can't figure out where you need help and what if you have a software program for your PMS that none of us have heard of, and that's why you can't do e-care plans. So we don't know that. It's literally not in IPHA's database. And what I have on you is 15 years old. from when we started Diabetes 10 City Challenge. It's 15 years old, so everything needs to be updated, and you have new people and new processes, and so the survey is very important, and then we can help guide you. I mean, I think every single person that I've talked to could do a pharmacy care at home. I mean, I used to be a long-term care, I owned a long-term care pharmacy, and I did more with the sandwich generation than I did inside the nursing homes. And, you can have me as your patient. No, you don't want me as your patient, but these are options that we didn't think about, right? We were in one lane, and now it's this great opportunity. But you don't get overwhelmed. Start with one thing, do it well.
Starlin, if I can reiterate just a couple things that you just said, that I think it will be important for the group to know. One is the formula for a successful network. We've seen it time and time and time again, are the luminaries directing the network facilitators. So when you said, we got to know, like, where do guide us? What do we need to do next? They really need to hear from the luminaries directing some of these activities. So if you're ready to go and you want to pitch something to Elevance or whatever, like that's the kind of details that they need the support on. But also I understand that there's been some new luminaries that have stepped up. So I would just like to offer, if our team can, if you'd like for us to meet with you one-on-one or as a group of leaders, just to kind of go through the roles and responsibilities, what we've seen effective, what we've seen maybe not so effective, just from anecdotal experience, we're more than happy to do that, maybe on a follow-up call. But it truly is, it is your network. And it's, when you talk about timelines, it's as quickly as you want to go and make those pitches. So it does take time. Like you said, there's a new RFP that's out. So those are seeds being planted that takes time to mature. But if you're starting to plant those seeds now, then with this strong leadership, you're going to see something, I feel very confident, pretty soon. So I know Byron's got his hand raised too. So I'll just pause there and just leave that offering.
Byron? You're muted, Byron.
You're muted.
Okay, I was muted separately, or I thought I was. I was getting ready to text Lauren. Can you resend the surveys? I'm sure I don't know whether but I know none of the rest of my staff did. So that's the second thing. We've been in for a long time, and initially had two main offices at Carrollton and Hall, doing the e-care plans, and I know quit. Can someone update me and get me up to speed so that I can get them going again?
So you broke up a little bit, but I think what I got was, did you fill out the survey? You've been in it for a long time, and you're wondering about e-care plans.
I need to have a refresher. Yes.
Okay.
We got that.
Just wanted to make sure that I got it.
And Lisa needs to be a beacon leader.
We got it.
Because she already is. And Rupesh.
All right. So there's a lot of great information that has been shared. There's a lot of information that I need to take one information at a time and see where I can plug it in my store. But at the current time, this is a $1,600 investment right off every year. And I'm trying to figure out what I can do more in my store with what I have to generate that $1,600. So in Illinois, with the help of Starlin, Laura, and Garth, we have managed to add a few services in my store through the training and certification, and I've done. So in Illinois, vaccination, which we do, through the program, we do the naloxone program, we do the MTM, we do the women's health, we do think one more program we do, you know, but and we do diabetes education. We don't get paid for that. We do asthma education. We don't get paid for that. I know Starlin is going to help me get there someday, very soon. She's pushing. I'm right at the gate, but we don't know how to do the billing. So, and then you guys talked about the long-term care, how I can convert. I'm a regular community pharmacy. I do bubble pack. I do home deliveries, and I talk to my patients once the delivery is done. So, and there is no potential of generating money there. So there's so many pieces of the puzzle, but I literally have to learn one piece first. So, I mean, in vaccination, I mean, as max as I can do, I'm pushing it with the number of patients. So I'm not going to generate any more income from there. That is a financial readiness that's available to me right now that I'm aware of. But I'm willing to learn if there's other ways of making more money.
It's the way you bill for your immunizations that's going to change.
Right. So
once we get you a documentation system that rides on the back of your PMS, then you can start doing evaluation and management, and you can get paid you're the first person that's gone through the Medicaid enrollment and credentialing. We got to work on the MCOs with you. And then if you've got anybody over the age of 65 on Medicare, that's pharmacy care at home.
I have a couple that I can try right away.
Well, you start slow and go.
So my question is, would you guys help us with the transitioning from a regular community pharmacy to have a long LTC NPI number? I mean, is there do you guys have a standardized process?
Leanne's there.
Yeah, I'll take that one, Rupesh. Yes. So part of the purpose for the pharmacy care at home program is that we can service any level of long-term care engagement. So I've got many pharmacies, over 20 now, that we have taken from being simply a community retail pharmacy, which I still think is an amazing thing, not just a simply. But we've taken multiple pharmacies from 0 patients without having a long-term care MPI all the way through to billing their first patient and then growing their program. So
Rupesh, in the short of it too, getting that LTC MPI and going through the process, working with Leanne and her expertise, that's probably been the single most important thing I've done for my business in 3 years. So I would highly, like, as you're speaking, I'm like, oh, I know what you should do, Dax. Like, you definitely need to start this process because I think it will make a big difference for you because you're already doing the services. It's not like it's paperwork at the upfront and then after that, it's already services you're doing. So I would highly encourage it, and I would be glad to talk with you on offline on my perspective of it.
I think that's what I would need to learn, you know, because I'm doing a lot of the services, which Starlin is aware of everything because I try to get her advice wherever I can from, but I'm doing it in a very manual format, and I'm trying to simplify my workflow. And I'm sure if there is a better efficiency format that I can use the better efficiency, which will reduce my work effort where I can do more. I don't want to cut down my work. I want to be able to do more within what I have. So I mean, literally, I would have to learn one piece of the puzzle at a time and start applying.
We are glad to support you with that.
I'm just thinking exactly how Leanne's thinking, and when I was a home infusion and a long-term care pharmacy, and everybody that is taking care of people on Medicare, whether they're over 65 or not, qualify for that pharmacy care at home. And because when it was called long-term care at home, everybody thought it had to be that long-term care level, and this is really being flexible, and it's really getting a lot of attention. I serve on the CMS quality assurance, and we reviewed the metrics for this back in December, and it really has pharmacy written all over it. So this is going to be something that's going to stay. It's not going to go back and forth because as Leanne pointed out, we're losing facilities, and some of the facilities aren't meeting the requirements anymore. They can't get staff to staff them. So care at home, and I don't want to go to a nursing home. I inspected too many of them. I want to be at home. So, you're stuck with me, Lauren. You're going to take care of me for the rest of my life.
I don't know about that. I have two
I'm going to
parents
have my
that need to take
pharmacist
care
at
of.
home. No, when we heard about it at the mid-year, I got very excited. And then I thought, no, I can't explain it all. Besides, you're tired of hearing me talk. And I thought, this is such an awesome opportunity for you, and you're already doing it. Just like naloxone, you're already doing it.
Right.
Lauren.
The challenge that I want to give the CPES and Tim, again, there are so many pharmacists, but talk to me, learn what I do, and make me $1,600, and I'm on board. But I want to hold you guys accountable for this, because last few years, every pharmacist that I've spoken to in Illinois that's part of CPESN, they have not been able to. Again, Byron may have done it, but we don't see the real value, because we are doing the work, we're getting paid. We are doing the work, we're getting paid, because we don't have the contracts. So I want to do something, but I also want to hold you guys accountable. Like, I will be required to pay, but I want to also generate if I do everything. So how do I hold you guys accountable for that?
Rupesh, you've been nominated to be the Northern Luminary for CPESN. So roll up your sleeves.
Byron, you kind of cut out. We only heard roll up your sleeves, really. Dang.
I was just warning Rupesh that he was going to be nominated to be a luminary for the northern part of the state.
Yes.
Let's generate funds right now. We need, with all the guards and Dave's hard work, I think they've done a lot of good things for us today. So hopefully CPESN does something great by the time I go to sleep tonight.
Cody or any of the other team members, did you want to respond to any of Rupesh's comments? Or
So I think one of the key aspects about CPESN USA is that our role is to help facilitate Illinois network to go after those dollars. And so at the end of the day, every local network that's been successful has sat around the boardroom tables within their own state and had those conversations and negotiated those contracts. So it's about equipping, because we're not a vendor. So the fees that you pay into CPESN go back to support the network. So think of it as more of we're an aggregate group of community pharmacies that are here to support each other. So it's more of these dollars that you're paying into go back to support your local network, so that Lauren and Starlin are there to answer the phone and then communicate, hey, we may have a payer opportunity, and getting around the tables of those payer opportunities. Sometimes they do come to USA and say, hey, what do you got in Illinois? And that's when your local leadership gets involved. And so when Byron suggested, hey, roll up your sleeves, like, I think those are the phone calls that we hope are coming your way. And we've seen it with other networks. We hope it's true for your network as well. So I guess I just want to just define that fine, line around, this is your local network to build, and we'll give you every resource we possibly can to be equipped to have those conversations and comparisons of what is fair pay for some of these network services, so that you can see those dollars roll in, and it's not just money you're paying out based on hope, but dollars revenue serving back into your network and to your pharmacy. Because that's our goal, right? Is sustainability. If it doesn't keep your pharmacy open, what good is any of this?
Right. The issue here is you're looking for 52 pharmacies or 55 pharmacies. That number sounds really small, but you're talking about 20% of independent pharmacies in Illinois. That's a really large number, and it is hard. Even when we want to get witness slips for an important bill, we barely can make 500 witness slips out of 350 pharmacies. So, I mean, these are the challenges that we have, and I'm sure Charlene and Lauren have already gone through this. So the target is large. I mean, 52 pharmacies is a very large number to get to.
I think one of maybe a really good call to action is I, I think what we also want to do is help support conversations that y'all have relationships for or with. If you've got a connection with the Medicaid plan, or you've got a friend who works with the health plan, or a QIO there, or some type of organization that's healthcare oriented that could offer grants. I think that's where we could really utilize Illinois relationships in order to have those conversations. So we certainly can join any and all of those calls to help facilitate those contract discussions and what services can you offer. And we know that language to speak to help them understand and be confident that you all definitely know what you're doing, and you just need to be compensated for the services that you're
So
provided.
we the lady with the magic wand to make it happen in Illinois, and she knows who she is.
Yeah.
That's Starling. Starlin and Garth, I would say.
Yeah.
So Cody, Christy Fowler of United
Mhm.
Healthcare was very adamant about getting something started, irregardless of what else is going on in United
And
Healthcare.
I would believe her.
Oh,
Yeah.
Yeah, I know. I mean, I've been on PKA work groups with her for 100
Right.
years, but she like came across the room to me and
Mhm.
said, "You got an RFP coming up in Illinois Medicaid. Can you get me details on it?" And immediately Garth pulled. I mean, we've been working with Jill Hayden, that's part of the MCO Medicaid Illinois group, and
Mhm.
if the more that we can get that around, and then I don't know who to contact in Elevance, because the person that's on the learning collaborative is not in that vein. They're on the East Coast, so I
Yeah.
don't have anybody. I mean, I tried to reach out to the Elevance person to find out if
I'll connect with Allison Haas tomorrow,
okay,
but she goes
good.
on PTO for a couple weeks starting
Yeah.
after tomorrow.
Well,
But I will connect with her and see. There's a lady by the name of Stacy Decemberly that is Allison's point of contact. So maybe what we could do, at least for the Elevance side, is to connect with them, or I'll connect you with them, whoever it may be, while Allison's out. And then second, I have a meeting with Christy on Thursday next week, so I can follow up with her too.
yeah,
and get that.
she told me she'd like to do something even
Yeah,
better than Elevance. So
yeah, of course.
I was loving
I love it.
competition, and I was judging their posters at PQA, and that's how this all kind of went going. And I
That's
went,
awesome.
thank you, Jesus.
Yes.
The other thing that may happen, and sometimes these happen really fast, but if you find yourself in a very heated payer conversation and you need someone to fly out or whatever for that's kind of gone through this, Starlin, Troy will hop on a plane for you for that. So just let us know, keep us updated on some of these heated conversations that come about. Because we want this for you too, and I think our team's pretty invested in making sure that this network takes off. So let us know how, like, if you need another perspective at the table or need us to jump on a conversation with Zoom to kind of push it to the next level, we can do that.
And we've had conversations with Centene with Molina. He made a presentation to this group. I don't know if we've had any follow-up. Has Lauren or Garth, is Garth still on here?
Garth is still on here. I think he would. I don't know if he's on the phone though.
Okay. Well, anyway, so things are starting to, kind of come to the top, which has been really nice. The biggest breakthrough for us was getting Medicaid to do the training so we could enroll in their credentialing impact. And that really kind of opened some things up in discussions before, it was closed door, no matter, I mean, we were working our inside tracks, Rupesh and I, but I mean, that's the biggest breakthrough. But again, what's been interesting is they did an update on how to enroll as a DSME or DPP provider for Medicaid in Illinois. And the person that gave that update took twice as long this time to explain impact, because she's trying to explain how to enroll in Medicaid's credentialing enrollment process to community health workers and RDs and things that haven't necessarily been involved in Medicaid at all. And she called it how we called it. It was just nice to hear someone else other than us say that their system was a little more complicated than it needs to be. But
and that's how those I think Rupesh mentioned 55 is kind of a target number, and that's how those grow. Like, you don't have to get all 55 today. Cody presented the data off 11 pharmacies that were successful in that small program. And as that builds, and as everybody starts chattering about these dollars that they're bringing in slowly, nobody wants to be left out of that, right? And so that's how it'll build. But just getting that promoted out there to the pharmacies that aren't tapped in, particularly if you graph it and there's areas that you need pharmacies, that's where you're going to target next to make sure you have geography covered.
Well, we're under pressure by CDC to raise our numbers from the small group that we have to something that's more like 50, so that it's across the state. So in order to maintain our grant status with the Illinois Department of Public Health, they're wanting more pharmacies involved in one aspect or another. They'd like everything, they want it instant. They want everything all the time. But
the other side of that too is if you start to promote LTC MPIs, that doubles your numbers.
So I'll definitely work on marketing that. But yeah, I really need my network to re-engage, come back. We'll do it together. We have a great support system, as you see. Any final questions or concerns, skepticism, you name it. Now's the time. If there's nothing else,
Hey, Lauren,
Yeah.
one more thought. Every network has been right where your network is.
Yeah.
And they've grown from that. So if I'm sensing discouragement, I don't want there to be any discouragement, because this is part of the growth of the network. And stay with it if you're on the line. We're very committed to seeing this get through and seeing you kind of get to the next level. And it just takes time. This is the hard part. This is the grunt work part. And then it starts to roll. We've seen it in 48 times, and it's going to happen for you.
I'm ready for it. I'm energized. I'm ready. I want to get my pharmacies taken care of. And patients. Byron?
Yeah, quickly, I want to reiterate the point I made earlier in our meeting. One thing pharmacists around here don't like to hear and turns them off immediately is when you say, you got to forget about getting paid for prescriptions. You're going to have to be providers. And maybe that will be the truth in the future, but right now we need both.
Agreed.
We should be paid for the additional services we provide, because that takes additional staff, and you still need to be paid for the prescriptions that we're dispensing out on and taking care of patients with. So don't start out by saying you got to forget about getting paid for prescriptions. That is going to make half the pharmacists here pissed off, and they won't listen anymore.
Yeah, I think that's a really good point. That's why those in Virginia was like, oh, we're out of this contract because we're not trying to make up for those dollars on the service side. So that's a really good point, Byron.
So I'm going to quote Troy. Today in our conference, Troy said, "You can never forget your prescription service because it's the secret sauce." Because that's what brings, I mean, we may be able to use electronics and robots to fill those and count those pills, but the human connection between you and your patients with those prescriptions is the secret sauce to better patient care.
Yep.
I have to go. It's my son's birthday. Bye.
Thank y'all for having us.
Yes, thank you guys again for coming. Thank
Thank
you
you all.
everyone for coming and participating. I really appreciate it. It means a lot to me. This is recorded, will be posted, and the slides will also be available. I know we didn't go through all the slides. If you find something in the slides, let me know. I will connect you to any of these team members and we will get you answers. So thank you all again, and we'll see you in June.
Thanks, everybody.
Bye-bye.